Well, thank you so much for joining from Korea and also Baltimore, late night time. So the talk is about translational neurocritical care research, but I think I'm gonna show you hopefully some of the clinical data I've done in the past, and currently I'm doing NIH studies, and I want to talk about how to build up translational neurocritical care research. And I'm a clinician, so I think for the audience today, I hope this is helpful and interesting. This is my funding disclosure. Some of the studies I'm presenting is supported by NIH and Hyperfine and NeuroOptics company. So tracing back to the roots where it first began, when I was in training back in Cleveland Clinic, I started taking care of a lot of LVAD patients, which is left ventricular assist device. This is heart failure patients, end stage, all the medical therapy fails, and you get onto this device to replace the function of a heart. Obviously, if you know the LVAD research and field, the evolution of this field has been pretty incredible. You can see the device from fourth generation to third generation already. This is more than 10 years ago. The device became smaller and more durable. The problem has been when I was a resident in Cleveland Clinic more than 10 years ago, a long time ago, actually. The problem was stroke. So people noticed that clinicians and patients, we noticed that they're having strokes. So in 2 years, 30% endurance trial is a clinical trial that people have done, cardiologists, and momentum is HeartMate 3. So third generation device was HVAD and HeartMate 3, two third generation devices. And the problem was strokes. And in the clinical trials, you can see in the rectangle that endurance trial HVAD had 30% at 2 years and momentum had 10% for this device. It looks really, really different. But then how they defined the stroke and how they counted the stroke was different. So it was kind of apples to orange. So it was not a fair comparison. But then the thing to remember is endurance trial was Medtronic, HVAD, and Momentum was Abbott, two big companies. So it turns out stroke was the problem and is the problem and still continues to be a problem. Um, this is an Intermex database. It's a well-curated registry database from Alabama. Um, uh, this is my paper after working on this for 2 years or so. And 2021, it was published in Circulation. Intermex propensity matched 6,000 patients. Kaplan-Meier curve, which is, I'm throwing out this all the terminology, but it's pretty standard in clinical research. Kaplan-Meier curve showed clear separation in these two devices when you look at the stroke. You can see here freedom from a CVA stroke and TIA is a mini stroke. So you can see clear separation between two devices at 12 months. And then second graph is basically hazard analytics. You can look at the early hazard and then late hazard. It shows clear separation on those two curves as well. So our studies show that one device was doing much worse than the other device, namely HVAD compared to HeartMate 3. Why am I talking about this? Because after this study, the device got off the market. So FDA decided to take this device off the market because of the risk of stroke. And Medtronic stopped producing this device. So I think I just wanted to make a point that device research is important, but always brain is really, really important in cardiovascular disease and cardiac devices. And that will determine the fate of the device that you develop. And this is one example of a stroke. You can see on the left side, this is a CABG patient, coronary artery bypass graft surgery. Post-op day number one is all clinical terminology. I'm sorry for that. But right MCA, which is one of the major vessels in the brain. You get occlusion, and then you have right ischemic stroke, left side of weakness, and this is CABG patients, so we call it CABG, and you have clear examination. When you have this surgery, we wake them up, and you can follow the neurologic examination. So you notice that if there's something happening, you have left side of weakness, we can do something, immediately recognize, and then do something imaging, and then do thrombectomy, which is an intervention. Whereas on the right side, this is acute myocarditis patients with ECMO. ECMO is a machine that supports the heart and lung. When heart and lung is not working, you probably heard about ECMO machine when we had a COVID pandemic because the lung was shut down. So we had to do a lot of ECMO support for those patients. VA is a veno-arterial, so it's a circulatory support when heart is not functioning with the VA ECMO cannulation. You can see ICH hemorrhage on the brain on the right side. The bright signal is hemorrhage. So this is a problem. The reason I'm showing this slide is because ECMO patients are sedated and paralyzed. There's no neurologic exam we can do. They're lying in the bed. There's no monitoring tool. So uh, this I'm explaining more than I'm used to. So I'm gonna talk fast. So I want to get into neurologic monitoring. This is the hallmark of neurocritical care or neurologic care in the ICU. So what is neuromonitoring? Obviously, there's different tools of neuromonitoring. So you're monitoring the brain, uh, uh, and the goal is to detect early neurologic worsening before irreversible brain damage occurs, because we want to do something to help these patients. Um, Neuromonitoring helps to individualize patient care decisions, and it tracks physiological response to treatment, and helps to understand pathophysiology of complex disease processes. That's all, pretty much everything in ICU. Design and implement management protocols. Does it improve outcome? Ideally, it's a really tough task, and it's hard to measure that. Non-invasive monitoring is preferred always, meaning do you want to violate the skull or just do non-invasive monitoring? Obviously, the problem is always the skull. Your skull is there to protect your brain. So when you have a fall, by any chance, you're iced, slippery, and then you have a fall, your skull is there to protect your brain. But the problem is when you have the skull, it's hard, all the technology is hard to penetrate that skull. So what you're monitoring outside of the skull may not be accurate. And sometimes we don't know what we are measuring. But we made a lot of progress on that, but still the technology is not there yet. Temporal bone is probably the thinnest bone you can see on the side, but occipital bone is twice as thicker than temporal bone. So this variability of the skull thickness also affects non-invasive neuromonitoring technology. So we have ultrasound, optical monitoring, EEG, wearable devices, really hot topic. But all of these technologies so far has not been able to address this skull issue when it comes to non-invasive monitoring. I just want to emphasize that frequent neurologic exam is essential because that leads to early and timely neuroimaging. So this is a hallmark of neurologic examination and neurologic care in the ICU or in the hospital or outpatient. But when clinical exam is limited, like ECMO patients or severe lung disease and heart disease, where they need heavily sedated, heavy sedation, and also paralysis to help with the patient's ventilation, oxygenation. We don't have exam to follow. That's where neuromonitoring is necessary. It's important to remember no single monitor measures the entire brain. Brain is a complex organ. I'm sure there's somebody who's doing research on the heart. You know, I don't want to offend anybody, but heart is a muscle and has one function, is to pump. But brain has complex function. It's got a lot of function and a lot of complexity to the organ. But in the ICU and in the hospital, you want to measure pressure, blood flow, metabolism, electric activity. And I listed all the things that we measure and then current tools that we use. Usually we do invasive monitoring. But everything has pros and cons, right? Non-invasive tools are easier to use and safer, but they may provide less precise information. Similarly, some modalities provide continuous monitoring while others offer only intermittent snapshots. So no single tool is sufficient and perfect, and we are relying on multimodal approach because of that. This is a guideline in the society. You don't have to read this. There are tools that we use like transcranial Doppler, EEG, and we have a ICP monitor, so a pressure sensor, and then you drill a hole and to the skull, and then you measure the pressure, usually from the right frontal lobe. And EEG, microdialysis, you can measure lactate, pyruvate, and see the metabolism of brain tissue. Although it's localized to one area, that's also an issue. And neuroimaging, pupillometer to measure the pupil size with the machine, which is pretty attractive machine. Autoregulation, brain's ability to maintain the constant perfusion over a wide range of blood pressure is called autoregulation because you don't want to have different perfusion in the brain when you have high blood pressure, low blood pressure, because then you're gonna get dizzy, you're gonna fall, and you may rupture the vessel. So brain has ability to auto-regulate the pressure and flow. That's called autoregulation. So we can measure that, but that has also limitation in translation. Nearest device, a lot of biomedical engineers here, so you are probably familiar with that. And biomarkers, blood-based or tissue-based biomarkers has been hot topics, and multi-omics has been around for a long time. Portable MRI is a new technology I'm going to be talking about soon. Um, I'm going to go a little bit fast because it's late in the night, although this is being recorded, so I should be professional. Um, so I think I'm going to skip this slide. I just want to point out because we have a lot of engineering and industry people who will be reviewing this talk. Um, there's a lot of engineering challenge because of the skull we have. And if you look at the left side of the figure, ECG, arterial pressure, ventilator waveforms, imaging, EEG, ICP, biomarkers, countless physiological signal. If you walk into our ICU, patient is hooked up with multiple lines, multiple monitors. We have so much data every day, every second. So problem is not the lack of information. Uh, we do have this information, but the problem is integration. They don't talk to each other. And physician is collectively integrate all this data and then make a complex decision. Although decision is always simple. Um, so I think when I look at the ICU of the future, it should be fundamentally different. Instead of disconnected monitors, we should have an integrated platform that combines multimodal physiology, imaging, biomarkers, AI into a continuous presentation of brain health. So that's where I see this is heading into, and technology is so important. Um, I'm gonna skip this slide. So these are some of the work. I'm gonna use ECMO as an example because I do a lot of ECMO research. That's the foundation of our clinical translational research in the lab. Um, ECMO is unique because these are the sickest patients we take care of. Heart and lung is not working. A lot of brain injuries happening, but we don't have good tools to detect the brain injury. It's a unique population that we learn a lot from these patients. Um, Before we move on, I want to implant this concept to engineers and industry partners who may be listening to this talk. Time is brain. So when you all talk about brain care or neurologic care, always remember brain is very sensitive. We have 100 billion neurons in the brain. And when you have a brain injury, you become a different person. That's the problem. You have some damage in the heart and lung. You're still talking. May have meaningful conversation. When you have brain injury, you are a different person. You have a dementia, you're a different person. You have a significant brain injury, you can talk, you're a different person. So brain is very important. And it has minimal energy reserve. So after 5 or 10 minutes, your neurons die. So we don't have a lot of time. There's no reserve, even though brain uses 20% of oxygen you utilize. So it is a very sensitive organ. So let's go to ECMO and ECPR. ECPR is a ECMO CPR, which is a resuscitation. So cardiac arrest patients, when your heart is not coming back after conventional CPR, chest compression and epi, ACLS, you do ECMO these days. It's been around, but it's a really, really hot topic these days, ECPR, which is just ECMO CPR. So this is our randomized control trials. Inception was the first multi-center study, RCT. I just want to point out that the leading cause of death in ECMO ECPR was neurologic. ACLS shock trial is cardiogenic shock trial, although 70% or more had cardiac arrest. Brain injury was second leading cause of death. Prague cardiac arrest this is also ECPR trial. Brain death was 25%. It's remarkable when you have patients being studied in a clinical trial and you have brain death 25%, which is just crazy. And then in addition to that, you have intracranial hemorrhage, so hemorrhage in the brain. So you can see brain injury is a huge issue in ECMO. And we did neuropathology study a long time ago, 6 years ago, when we looked at the brains when they passed away, the ECMO patients, about 70% had brain injury in the brain. We did follow-up studies. There are a lot of microhemorrhages and small hemorrhages and big hemorrhages. So brain injury is a problem. And this slide shows that upper side is ischemic stroke and lower side is a hemorrhagic stroke. Just is it ischemic stroke, bleeding type stroke? When you have that, your mortality goes up by twice. That's what it is. This slide is talking about. So impact of ABI on 90-day mortality is pretty high. And when you talk about cardiac arrest, I'm moving a little bit fast. My apologies, but I just want to cover everything. Primary injury and secondary injury. When you have a cardiac arrest, there's a lot of mechanism, but primary injury is set by ischemic duration, and secondary injury involves over hours to days through complex reperfusion, inflammation, vascular issues, and metabolic processes. And this primary injury, of course, you have to control how long patient is down or how long brain is ischemic. And the secondary injury is this after that. So we want to monitor the secondary injury because there is an opportunity to improve the outcome in these patients if you improve the secondary brain injury. Maybe that's an overstatement because we haven't been able to successfully improve secondary brain injury target, but that's an active research area. This is just showing that ECMO CPR, again, still ECMO CPR, so ECPR patients. So you're down, your heart is not coming back. You're just to describe this patient, a patient going to the ED, still heart is not coming back. You cannulate. So by the time you cannulate, 40 minutes, 60 minutes, it can be varied depending on your system. By the way, in Korea, only big academic institutions, US as well, can do ECPR. The system, having this system is really, really challenging. Um, Anyways, so it shows that after 40, 60 minutes of low flow means you're giving some flow with chest compression. There's a Lucas device, which is automated chest compression device, or you can do manual chest compression, which is a low flow. We say that when you do chest compression, there is 20% of cardiac output with chest compression. Although I think it's the overestimation, probably not 20%. Anyways, this data show basically a lot of patients after 40 minutes of low flow time or downtime, the chance of recovery is really small. That's what it shows. And the timing matters. And this Minnesota place, Yiannopoulos, he's a pioneer on ECPR. And he revolutionized the field of ECPR. And his center at the Minnesota he does better than any other centers. His data shows that his outcome is much better than other centers. I just want to point out, engineers, you may be interested in this slide, showing that our failures from translational science aspect, clinician standpoint, for neuroprotection, neuroprotective therapy, brain injury, and cardiac arrest, we failed. Everything, we failed. Preclinical model, it worked. And then clinical model, when it comes to the patients, everything failed, except for TTM, targeted temperature management, hypothermia. So hypothermia has a multimodal approach or mechanism. It helps with neuroprotection. And cardiac arrest still kind of controversial because three, four trials were positive for TTM, hypothermia to help with the neurologic outcome, but other two trials, three or four trials, were negative for neurologic outcome, including TTM2, and then ISCAP trial just came out. The final publication is not out yet. Anyways, so this is a TTM. I just want to show some of the data we did with NIH studies. And this is showing that neuronal death increases sharply with ischemia duration. So after a couple minutes, really, neurons tend not to come back if there's a complete cessation of flow. But if there is an early post-ROSC, a return of spontaneous circulation, blood flow to the brain recovery, to thalamus, hippocampus, and cortex, that was associated with improved neurologic outcome, highlighting a critical early reperfusion window in these patients. And this article we did a couple years ago, early cortical gamma recovery, gamma activity are tightly coupled and predicted neurologic outcome, highlighting a hyperacute window for intervention. So blood flow may matter. It comes back to autoregulation. This is autoregulation curve. You can see mean arterial blood pressure, wide range 50 to 150. You maintain the same blood flow to the brain and perfusion. It turns out CO2 is a really important factor. So now physiology, CO2 is arterial CO2 is a potent vasodilator. PaO2, you can see oxygen. You have to have a pretty significant hypoxemia to cause blood flow to go up. So just want to point that out. And autoregulation is important because every patient may have different autoregulation window and it gets shifted. So everybody may have different target blood pressure or to optimize the perfusion to the brain. And this is our NIH study, Delta ECMO ABI. We're particularly interested in autoregulation function. In ECMO patients, you can see the nearest device and the sick bay, which is a second-to-second continuous waveform data clinically used at Hopkins. And not every center has that continuous precision medicine platform. And nearest machine, we put it in the frontal patch, basically correlation between regional set in the brain and then map, continuous map. That's how we measured COX, which is an index for autoregulation. And we thought low pulsatility matters and also PaCO2 matters. So when you have a low pulsatility, it turns out ECMO pump is a continuous flow pump. It's a non-physiologic. There is no pulse. But our heart has a pulse, right? Our vessels and small vessels, endothelium, they need pulsatility to maintain the endothelial health. Nutrition exchange and oxygen exchange is vital to have pulsatility, it turns out. This is from all 1950, 1960, all really good, well done preclinical studies. And we thought in VA ECMO, when they are cannulated, low pulsatility and also rapid changes PaCO2 probably impact the function of the brain. That was our hypothesis. And it turns out it did. So we measured the autoregulation indices. It shows that in the first 12 hours, autoregulation is more impaired with patients with acute brain injury, ABI. And this is just looking at the data differently. So when you draw the curve and then area under the curve, there's a clear separation after hour 6 or 7. The patients with ABI has more autoregulation impairment, Cox AUC, and you can see on the both graph there's a clear separation after 5 or 6 hours of ECMO cannulation. And we also measure. We have a huge biorepository for ECMO patients. Every patient who's cannulated and admitted to ICU, we consent and we collect all the plasma daily. So we have 200 plus patients with daily plasma samples. When you look at that, endothelium 1, which is endothelium dysfunction marker, with patients with impaired autoregulation had elevated endothelium 1, along with tau, neurofilament light chain, GFAP, brain injury markers were elevated as well. And this is an interesting study on the left, ovine model from Brisbane, Australia. John Fraser's group. He's a pretty famous pump crate ECMO person. He has a very stable ovine model that he can maintain 24 hours of ECMO in this model, which is impossible, by the way, guys. This is really hard to survive. Any swine or ovine model surviving a large animal, for 24 hours on ECMO, it's just an impossible task, but he can do it. I don't know how, somehow he's doing it. But anyways, this is to compare pulsatile ECMO and non-pulsatile ECMO. And it shows that when you have a pulsatile ECMO, you are less dependent on vasopressor. Your lactate marker gets better, and then your brain ischemic markers get better. And on the right side is pulse pressure data from our clinical data. When you have a pulse pressure less than 10 in the first 12 hours mean pulse pressure, you are also you have you're more likely to have ABI in VA ECMO patient. And that was also shown in autoregulation. If your mean pulse pressure is less than 10, your autoregulation was more impaired, as represented by this box plot or violet plot. And delta CO2, it turns out when patients are sick, you don't clear the CO2 well because you're not ventilating well, you're not oxygenating well, you're sick. So CO2 gets accumulated in the body. And it turns out when you cannulate with ECMO, we clear out the PaCO2 pretty rapidly because we can control the physiology with ECMO. That large delta PaCO2, we found that that was associated with hemorrhagic stroke in our Hopkins data, and clearly showing the probability plot and histogram. And it showed in our also continuous sick bay platform with Cox. It shows autoregulation is more impaired, larger the delta PaCO2 is in the first 24 hours, along with the ABI data consistent with delta CO2 association with ABI. We thought it was important to go back to the swine lab or animal lab, and we randomized the rapid CO2 correction, normal correction, and then slow correction. It turns out when we randomize that in animal model, everything is controlled because patients, a lot of things are confounded. Rapid CO2 correction group had more impaired autoregulation and more ischemic injuries in caudate putamen and also hippocampus. This is oxygen data. It turns out if you have too much oxygen in the blood first 24 hours of ECMO, you are likely to have more likely to have a poor neurologic outcome. If you have refractory hypoxemia in VV ECMO, which is veno-venous lung support, we found that it was associated with also ICH. So you continue to have oxygen issue or oxygenation issue in ECMO patient in the first 24 hours, you are likely to have more brain injury. These are all trainees, Mays, Arkawaz, and Arman Akbar. He's in Columbia Thoracic Surgery. Mays is This is unnecessary. I'm wasting my time. So based on this data, I chair the guidelines. So this all these NIH studies and clinical data, translational data made into guidelines, and then it was published 2 years ago to help the clinician how to manage neurologically in ECMO patients. So let's go back to neurologic monitoring. This is a part of the figure and recommendation. We have something called Delphi method. A lot of people, 30 plus people gather together, and then we cast a vote, basically. We agree or not, and then we make a recommendation how to monitor this patient, how to manage this patient. So this is just an example showing that. And unique about Hopkins is 2017, um, when I started out with Hopkins, we implemented a neuromonitoring protocol. So TCD, EEG, just available tools, but we standardized the approach. And with that, we had more acute brain injury detected and diagnosed. Because of that, we thought neurologic outcome was better. This is one example. I talked about pupillometer. This is automated pupillometer where you can shine the light with the machine and it detects how fast the pupils are moving and how large the constriction of the pupils, and it measures. They have their algorithm, which is not published, and then they come up with the NPI, neurologic pupil index. And this is an example, significant asymmetry of NPI showing that there is a huge brain injury, diffuse anoxic brain injury. So this is a good example. A neuromonitoring device can be used clinically really well and is helpful. So now pupillometer is widely used globally. It wasn't the case, a long time ago, but this device, a simple solution, and is really helpful in the clinical practice. Because if you do the pen light, it's hard to know sometimes because you're seeing with your eyes. So a lot of patients, pupils are so small, it's really hard to see if pupils are moving or not. So we're doing CECMO. This is ending in September. It's a clinical trial, multi-center study, using portable MRI and pupillometer to Neurocritical care devices, and it's industry-sponsored study. We are looking at pupillometer in ECMO patients and its impact on neurological outcome using MRI as a imaging tool. So another example of safe, I'm doing well with the time, I think. Safe MRI ECMO study is also a good example for industry partnership for those companies, industry out there in Korea. I think this is a good example. One simple clinical need and idea can lead to multi-center study and then translation, and it's good for academics, patients, and also for industry. So we wanted to make a paradigm shift. So I developed a neuromonitoring protocol. It was a clinical protocol. It helped, but at the end of the day, you want to image these patients early. So early neuroimaging, early intervention, and better neurologic outcome and prognostication. So this portable MRI came about 10 years ago or so, but Kevin Shetty is the first one to try this in the ICU, not ECMO patients, but neurocritical care patients. Yale, they did a feasibility study and then published in JAMA Neurology. The point about this portable MRI is 0.064 Tesla compared to 1.5 Tesla or 3.0 Tesla we use conventional MRI in the clinical practice. So really, really low magnetic field. But the concern is okay. So you can move this device around in the ICU. What about the resolution? That's always the concern. Um, but simple question was, I mean, ECMO patients, we don't want to move this patient out of the ICU, and then portable CT scan, although some institutions have that, radiation is always an issue. You expose radiation to a lot of patients around in the unit, so it's a problem. So simple question is, can portable MRI be used in a ECMO patient? ECMO has a metals, right? And MRI is not compatible with metals, but it's a low field. Can we just do it? So that was a simple question, and from the clinical unmet need. And we did ASTM. We follow American Society testing materials. Whenever you have a new device and safety concern, you have to follow this criteria in America. And you measure displacement force and heating for MRI. We tested a lot of different cannula, 24 French, 16 French, 15 French. It's just the size of the cannula, double lumen cannula, and balloon pump, intraarterial balloon pump. That's IABP. And you measure the gravity force and then measure displacement force of each device. And then you compare that. It was much less than gravity force, which was good. Heating, you measure the heating. ASTM standard is 1 Celsius degree, and you measure the temperature while you're running the device or MRI for each device or cannula, 15, 24, pacing wire, double lumen. So you can see it was much less than 1 degree. And we went to swine model after the phantom model, and we killed several pigs, but no visible motion, no displacement forces of the cannula when you run the MRI. So it's just a typical kind of translational model with a new device. And then you do preclinical model to show the safety, and then we did multi-center study. And I was published in Circulation a couple years ago. And you can see while on ECMO, you do MRI, which was the first ever done. 44% while on ECMO, it was high. And it was more sensitive for ischemic stroke um, than CT scan. Okay, so these are the examples. So left cerebral ischemic stroke, small one on the top, and the mesial occipital stroke in the middle, and then right frontal SAH, trace hemorrhage. So you can see on the left side and the right panel, you see multifocal stroke. Compared to CT scan, this 3 hour difference between CT scan and MRI is this young patient with ECPR. You can clearly see in MRI, the imaging quality is not bad. That was the point of this slide. And then it evolved. So, based on our studies, preclinical and clinical studies, it really evolved, and we tested a different device, swan guns, balloon pump, chest tube, ventilator, epicardial pacing leads. The paper is coming up soon from the lab. Um, and we did also LVAD, which was not safe. Impella study was done in our lab. So all of these studies came out from this initial question, clinical question, simply, can we do photo MRI on ECMO patients? So let's go back to translational neurocritical care. So examples I presented today all follow the same translational framework. And we don't begin with the technology, basically. We begin with unmet clinical need. I emphasized that a couple times. As a practicing intensivist and also scientist, I more clinician side in this phrase, I encounter so many challenges at the bedside, right? Taking care of patients. There's so many limitations. There's so many things we don't know, and existing tools cannot solve any of this lot of issues that we face every day in clinical practice. Then we bring together a multi-D team, clinicians, engineers, neuroscientists, AI now, industry partners. We really think about the solution and then work together, and that partnership is critical in innovating the solution for patients. That's what we want to do, right? We want to help patients at the end. Obviously, industry, you guys want to make money, but from academic side and also industry too, I think you want to help patients. I think that's the motivation for all research we do. This is one example, translational approach, which is called SENTINEL for Air Force funding. It's a wearable in-ear multimodal neuromonitoring platform. You may know, some of you guys know Nitish Thakur. I've been working with him for 10 years now. So idea is pretty simple, transform the ear into non-invasive window to the brain. We develop sensors and AI-based analytics and really compact wearable sensor that can be translated into ICU and ED to monitor the brain and heart. So a simple solution. This is more applicable in ED triage setting and the military setting than obviously ICU, where everything is available. And this is just a framework, first in the ED pre-hospital setting, and second in the ICU. I'm really interested in neuromodulation. In this case, auricular vagus nerve stimulation, and that impacts. The model is pretty significant brain injury and the coma disorders of consciousness if patients aren't waking up. Can you modulate, help these patients to wake up? Uh, Pretty simple question, but very ambitious question as well. You need the team. Anytime you do a project like this, translational science between engineers and um, um, development or device development and clinicians, you need a team and industry partners. Um, that goes without question. Um, As our monitoring technologies mature, the next step is to make critical care devices more intelligent, not simply collecting data, but using physiology to guide clinical decisions and possibly automate aspects of patient management. I think a lot of work is being done, especially automated system, robotic surgery. There's a lot of Hopkins investigators working on different projects. And this GoldEVAC project we've been doing last couple of years is to have automated resuscitation system with ECMO. And that was a pretty interesting project and with the hemorrhagic shock model, especially military setting, it's a DoD funding. And then the second thing is on the right side is really autonomous intervention concept for ischemic stroke. So when you have a thrombectomy, can you navigate the vessels and you simulate all this variation in anatomy to the brain? And this program it calls for robotic automated. I'm laughing because it sounds ambitious as I'm talking. Um, but automated ischemic thrombectomy setup with microbot. So I think things are changing with digital twin model and simulation and AI and robotics. These are pretty hot topics these days, and the future of ICU is probably everything, every system in the ICU should be integrated together. So the clinical decision becomes much more simpler. This is one of the industry partner project we do, capture pain projects, looking at waveform analytics to really have objective pain scale after the operation. Pretty simple question with infrastructure we have and industry partnership that we can answer this simple question and develop algorithm, potentially sensor as well. And this is another example that we do in the lab and predicting clinical deterioration several hours before conventional recognition, clinical recognition. So we're doing also this AI-based research, clinical research to help with the patients who are admitted to the hospital. So we're getting to the end. I think I believe that the field is heading into more technology in neurocritical care. Um, but the question is the same. Physiologic questions remains the same. How do we continuously measure brain activity, neural activity, tissue health or brain health, and brain perfusion and pressure? Those are the things that we are interested in as clinician at the bedside. Um, but the common engineering challenge, again, is the skull. Um, while it protects the brain, it also limits our ability to measure, image, and treat neurologic disease. So I think this slide shows upcoming and or already in the research space, widely available devices, advanced optical imaging. Our APL has a hologram-based optical sensor, and multimodal neural interfaces, functional sensing technologies like functional ultrasound, photoacoustic, focused ultrasound. These are not new anymore. Diffuse correlation spectroscopy, all of these things uh, uh, really to better understand physiology in the brain and how do we monitor these patients non-invasively and get the accurate information to understand what's going on with these patients. And obviously AI to integrate everything together. You know, these days we mention AI all the time. Um, okay, next. How can I move? Okay, so to conclude, my particular research, our focus has been driven by a simple principle. I want to say. Really, it starts with unmet clinical need to help patients. And obviously, needless to say that we all need a comprehensive team, collaboration between clinicians, engineers, and um, regulatory industry partners. And these technologies will help this patient. I hope that happens. And the really important thing is to the audience, industry partners, and investigators in Korea, I think it's really important to collaborate together, especially FDA engagement and getting the validation studies and getting the right infrastructure and data to answer simple question that we face every day in the clinical setting. Thank you for your attention. Happy to take any questions.